Multiple myeloma is a disease of a type of white blood cell called a plasma cell. And plasma cells are responsible for making antibodies, and antibodies are responsible for helping us fight off certain types of infection. There's two major types of white blood cell, the B cells and the T cells. If you turn certain B cells on the wrong way, they can develop such things as lymphoma, or other types of leukemia, acute lymphoblastic leukemia, for example. But in other cases, you can develop, a patient can develop multiple myeloma. And this is usually seen in older patients. The average age is in the early 70s. But there are some patients who are relatively young. I think our youngest patient was in their mid-20s. And it can occur as time goes on in a much older patient population. It's not clear what causes it. It could be due to radiation exposure. We do know that patients from Hiroshima and Nagasaki had about a twofold increase in incidence of myeloma, but that was about 20 years after the atomic bomb exposure, and it was a lot different than some of the acute leukemias, which are much more associated with radiation exposure. There's some idea that potentially some toxins may be involved, but that's sort of not clear as well. It can present, if somebody has high calcium, they will have the signs and symptoms of high calcium. They can have altered mental status, interestingly enough, constipation due to the high calcium. And so they just don't feel well, and that's easily shown on a blood test when the calcium's too high. Sometimes the myeloma will present with bone pain. That's often a common presentation. The patient will have back pain, and they often will get worked up for back pain in terms of, is this a disc or whatever, and it may not be picked up right away, especially if the patient doesn't have lytic lesions and they just get a plain film. And the other would be, as mentioned as part of the CRAB criteria, anemia. The patient will have the myeloma crowding out their bone marrow, and so they'll become very anemic. And the other is they'll have signs and symptoms of renal insufficiency or renal failure, where the myeloma protein has started to gum up the kidney and damage the kidney, and thus they start to go into renal failure, and that's altered mental status, changes in urination, just feeling terrible. Diagnostic testing for multiple myeloma involves a variety of both tests from the serum or blood testing, as well as urine testing and bone marrow tests and x-rays. So we'll start with serum. You obtain a total protein that shows that it's often elevated, may not be, but often is. Serum protein electrophoresis, immunoelectrophoresis. This helps establish that there is a monoclonal protein as well as what type it is. If those aren't seen and we're still suspicious of myeloma, serum-free light chains are done, because if those are elevated, that's also a diagnostic test that's very helpful for proving the disease. We also test in the urine for the presence of monoclonal protein by both electrophoresis and immunoelectrophoresis, which again helps identify which protein is abnormal. Patients will then have a beta-2 microglobulin and a albumin levels, which help establish stage. A bone marrow test is almost always done. This helps us in terms of telling us what percentage of plasma cells are in the bone marrow, and it also tells us cytogenetic risk, because we now are routinely recommending that all patients have some form of cytogenetic examination, because there's certain chromosome abnormalities that are associated with good prognosis, especially with certain types of therapy, and there are ones that are associated with worse prognosis. The other tests that are obtained are skeletal survey, and that tells us if there's holes or lytic lesions in the bone. MRI, especially if the patient's having back pain, but now people are starting to look at this to look for signs of occult or hidden disease. And PET scan in the U.S. in particular is being used to look for aggregations of plasma cells, or plasmacytomas they're called. The treatment for myeloma has rapidly evolved over the last 20 years. When I was in medical school back in '82, the median survival was 3 years. In other words, if you had 100 myeloma patients requiring therapy, 50 would be deceased within 3 years of initiation of therapy. The median survival now is well over 8 years, close to 9 years. And that's because we've been able to incorporate a whole new set of treatments for multiple myeloma. Nowadays, a lot of people are looking at using an immunomodulatory drug. Lenalidomide is sort of the latest one. Thalidomide was the first one used, and there's a new drug that's in clinical trials called pomalidomide. And that's oftentimes combined with high-dose steroids, dexamethasone being the gold standard. And there's been some studies looking at higher dose versus lower dose dexamethasone, showing that they're probably equivalent, although you might get a little bit better response with higher dose dexamethasone if the patient tolerates it. And there's another drug called bortezomib, which is from the class of agents called proteasome inhibitors, and these also inhibit the multiple myeloma cell growth. And the classic one being bortezomib, that's the first one that was approved for use, usually combined with dexamethasone. So we're seeing that you now need to start thinking about combining these drugs as part of your induction therapy. And then you can use this to generate great responses, and then make a decision. If this is a younger patient who is what we call transplant eligible, their stem cells are collected and they receive high-dose melphalan, or usually a melphalan-containing regimen, and then the stem cells are given more as a rescue from the toxic effects to the bone marrow of the high-dose melphalan. And those patients seem to also do very well if they're of the age and physical status that they can tolerate this type of therapy. And the big goal now is to try and generate as good a response as possible so that you can consider such things as maintenance therapy to maintain that response. If I had multiple myeloma, I would, first of all, want the diagnosis established. I'd want to have certain testing done to help me establish the type of severity I have. That includes, as part of a bone marrow test, cytogenetic testing, because that will help assign risk. And that will help guide me in terms of what types of things I might consider. If I'm a very young person, I want to have the most aggressive approach to treatment. That usually is some form of induction therapy after establishing the diagnosis, and then followed by stem cell transplant. In very young patients with very high-risk disease, there's at least consideration for transplant from another person, but these are the exceptions because most patients who are diagnosed with this disease are older. If I'm an older patient in my late 70s, early 80s, I'm thinking of, again, having all the testing done to help establish risk. I'm looking for some type of treatment that's going to allow me to have good quality of life and that I can tolerate. And that's been a big issue with older patients, is some of these drugs have toxicity, and if you're not able to deliver the therapy, it doesn't do any good for the patient. So it has to be therapy that's well tolerated. And then I'm just going to be starting to think, after a good or great response, then trying to maintain that disease response as long as possible so I don't have to get treated again. And that again implies that I need to receive something that's going to allow me to maintain good quality of life and not have to be debilitated by therapy. It's no good if I'm spending all my time in the hospital because I don't tolerate the therapy, or if the patient's not able to receive it because there's too much toxicity.